Myself, Dr. Jibran Ahmed presents to you Simply Pathology, and today we are back with a very important session. Today we are going to start off with the exam slide rapid revision series. This is a very anticipated series from all of you, and I do understand the importance of this series. So today we are going to start off with this series. So initially I am just going to give you a brief introduction to how this series will be conducted. So this series will be having approximately 10 to 11 videos, okay? And in this series we are going to cover 100 most important or most commonly asked exam slides, okay? So this will be covered. In today's session we are going to see the basic introduction to the series, and we will discuss 10 very important exam slides, okay? 10 very important exam slides. So without wasting any time, let us begin. So a brief introduction. So remember, the aim of this session is that it is not a teaching session. Rather, it is a rapid exam related slide revision series which is going to help the exam going students to revise before the practical exams, okay? Now for detailed lectures, you can always visit the individual systems which has been covered in details in the website and the application. So who all can benefit? Ideally, any postgraduate resident in the field of pathology, they can benefit. Why they can benefit? Because you will come to understand that what is the line of questioning. So, you know, just reading a particular topic and going on and on about it does not serve the purpose, because you will not be able to reproduce each one of them. And it also doesn't serve the purpose because you don't know why you are reading those things. So when we are asking you questions, okay, so many questions are practical based questions. So you will also develop that habit that, okay, I have to read in this particular pattern because such questions are getting asked. So you will understand that what are the portions that you should lay a lot of stress on. Okay, so ideally it can, benefit all the postgraduate residents, but it is going to benefit the third year residents, exam going residents maximally, okay, or those who have gone through our lectures in detail. So you can correlate each and everything. It can also benefit other undergraduate students as well. Now remember, this series is aimed at focused revision in a very short, concise manner. Now there is a myth about writing slide description. So I want to clarify that myth to each and everyone, because a lot of questions have been asked to me regarding slide descriptions. Now what I have seen that, you know, many students, okay, they are, just by hearting the slide descriptions. No, if you are just going to by heart the slide descriptions of the different slides, okay, so you are going to, suffer very badly. Why? Because even with the same diagnosis, okay, two slides having the same diagnosis can have different description. So you cannot rote learn. So avoid rote learning of slide descriptions. Okay. So for this reason, we have already started for the last 5 years. We are having slide discussions in our WhatsApp groups. Okay. So you are given the opportunity to write down, and we also share sample slide description. Now those samples are not meant for you to rote learn. Okay. They are meant for you to understand and for practice. So remember, you should avoid rote learning of slide description. You have to practice. A lot of different slides is already available in the website and application along with the description so as to help you, but do not rote learn them. So what will be included in this particular series? So the most commonly asked exam slides, okay, which in the practical MD DNB exams will be included. Initially the 100 most commonly asked exam slides will be included. Later on, as time permit, we will keep on adding more and more slides. Most important relevant differentiating HP features will be highlighted. So you do not have to read each and everything in details, because one day before your practical exam, or say you are having 3-4 days before the practical exam, you want something very short and concise. Okay, so we are going to highlight only the most important histopathological features. All important Viva and OSCE questions will be discussed. Not only discussed, we are going to add all the answers, okay, one-liners and all the short answers, okay, will be added, so that whenever the question is asked, you can rapidly answer them, or it is just, as a reflex, you can answer them in the exam. So answers to shorter one-liners are included. Relevant differential diagnosis will be highlighted. Remember, what is the concept of differential diagnosis? Many students, they ask me, sir, can you give me a particular book which is having differential diagnosis? Now my answer to you is, you go to any online resource, they are having very beautiful differential diagnosis list, but you cannot by heart differential diagnosis. Now remember, how do you understand about differential diagnosis? So suppose if when you start reporting a slide and then you think, okay, I have seen this feature in another slide too. So such features are also seen in one such other diagnosis. So then only you go and see the differentiating features, and then you will remember the differential diagnosis. Else it is not possible for you to remember each and every differential diagnosis. So what we will do is, we are going to discuss about the differential diagnosis for some relevant slides only. Okay, that is very commonly asked in the exam. Okay, so this is the concept of DDs. And remember one thing, that in details we have discussed about the differential diagnosis. We have discussed in details about the classifications, the prognostic factors, and everything in detail has been discussed in each and every chapter. So we are not going to discuss each classification in detail, or each prognostic factors in details, or individual differential diagnosis in detail, because they have been covered. We are just going to cover the relevant ones, okay, in short. Okay, remember this point. Classifications, as I have already said, the latest WHO 5th edition classification has been shared with all the enrolled residents in our WhatsApp group, so it is not going to be repeated here again. Remember, one very important aspect of our discussion is, we are not going to discuss anything system wise. No, because everything in details has been discussed already in the website and application a lot of times, and they are all given system wise. Because what is the reason, what is the rationale? Because in the exam, the questions, they are never asked chapter wise. So in the practical exams, maybe in the morning or maybe today, you are having you say hematology and cytology slides. Maybe next day you are having your histopathology slides along with fluids. Okay, so they are always asked together, and remember, nothing is asked chapter wise. So you have to get a mind setup that that you do not see things chapter wise, because once you have the habit of chapter wise learning, then in that case you will not be able to answer. So always remember, in the practicals your application has to be spontaneous and not chapter wise. Remember this thing. Also, we have included proper case history in every case. Okay, in every case we have given a proper case history, and that case history is going to give you a lot of idea about the case. Again, this is not for rote learning. This is just to give you a practical exposure. Okay, now remember one thing over here. What we are trying is, we are aiming at that we are going to give only 2 minutes will be given per case discussion. But today I think we will give around about 2 to 5 minutes per discussion, because today is the first lecture. So we will be going a bit slower. In the later lectures, we are going to increase the speed. Okay. Once you people become accustomed, then we will increase the speed. Okay. So what all slides will be included? So slides from systemic histopathology, hematology, cytology slides, including all slides from organisms and fluids will be included as well. Okay. Even the bone marrow aspirate slides will be included. Okay. Now, how to approach this series? So first and foremost thing, remember, keep our notes. So whatever notes, simply pathology notes that you are having, just keep it with within your hands. Why? Because everything will be based out of that, with few additions from our side, so that this series will not be something new for you. It will be a rapid revision of already something that you have learned. So that is going to help you. Along with that, you can keep Robbins, Orels, Tejinder Singh Kothalkar at Tejinder Atlas as well as Kothalkar. You can keep in front of your in your hand just for reference. But mainly you keep our notes in your hands and Robbins in your hands. Each case history is carefully thought through. So take information. So whatever case history we are giving, we are not just giving randomly, or we are giving according to the particular age, and the history is also matching that particular diagnosis or that particular case. In the exams, remember, you get 5 minutes for analyzing and writing down the whole description. There is no time to wander in the exam. You have to be fast, you have to be quick, you have to be accurate. So focus on how to answer in short. So this series is going to address that only. Okay. So what we are going to do is, we are going to do a very rapid revision of whatever we have already read. Okay. So that in the exams, when the examiner is asking you certain questions, you are able to give answers very swiftly, so that the examiner knows that you know your case. So in the exams, if you see the total practicals, I think they are of around 600 marks, if I am not wrong, the entire practicals. And if you see the total number of slides, usually or in some colleges they are, there are 25 slides, and in some colleges you are having approximately 35 slides. So on an average, total 33 to 34 slides are there in the exams, and each is carrying 10 marks. So 5 marks is for your diagnosis and 5 marks is for the description, and it might vary also. So basically, usually what we have seen, that the examiner is taking your impressions as well as your description, and some marks is there for your viva too, how you cross question and answer. So basically, you are basically not only marked on the diagnosis and for description, but also on how you answer and justify your diagnosis. So what I want to tell you, that this is going to comprise nearly 50% marks, okay, total marks of your practicals. And not only that, based on these, your grand viva will also be based on this. So more than 50% marks will be based out of what you answer over here. Okay, so remember, and the performance also decides your questioning in grand viva. Okay, so the way you answer the questions, it is also going to decide what questions will be asked to you in the grand viva in the exam. Therefore, this series is of utmost importance. Practical application based discussion, important questions would help in retaining the concept. So what is the meaning of this? Suppose, okay, you have you have learned a particular topic, and suppose that topic has they have, for example, around 15 to 20 points. So out of those 15 to 20 points, maybe around 7 to 8 points are very, very important to understand, and they are repeatedly asked. So this is going to help you retain the concepts. Maybe you have read something somewhere, but you don't know how to apply and what to make out of that information. That will be cleared in today's discussion. And in every video, the list of exam slides which are discussed will be mentioned prior. So suppose when this video will be uploaded, so when you go into the discussion section, or you go to the video description section, there we will list that case number 1 is this, case number 2 is this, case number 3 is this, case number 4 is this. So what is going to happen, that you will know, okay, this slide is present in this video. Okay, so let us start with the case number 1. So what do you see over here? So you see that there is a 32-year male presenting with nasal obstruction, okay, and a nasal mass which bleeds on touch. So on examination, you see a polypoidal mass in the nasal cavity. So what do you see over here? You see a section of the tissue composed of variable sized sporangia. So they are composed of multiple variable sized sporangia, okay, and each such sporangia is composed of several sporangiophores or endospores, okay, endospores in the stroma of this polypoidal mass. Now the stroma is also comprising of chronic inflammatory cells, as you can appreciate over here. So they are comprising of chronic inflammatory cells, as we can appreciate over here. Okay. So what is the diagnosis? Yes. What is the diagnosis? The diagnosis is rhinosporidiosis. So what are the most important histopathological features? So you will see sporangia of various sizes located in the stroma of the polyp, largest of which is usually located immediately subepithelial. Sometimes the sporangia might rupture also, as we can see over here in few of these sporangia. Okay. The overlying mucosa may show squamous metaplastic changes, but it is not shown over here. Mature sporangia ranging in diameter from between 100 to 450 micrometer with a thick chitinous wall containing sporangiophores or endospores in different stages of development. Sporangiophores stain basophilic, okay, and they are 7 to 9 microns in diameter. The stroma is composed of moderate to abundant chronic inflammatory cell infiltrate comprising of lymphocytes, plasma cells and macrophages. Sometimes mixed inflammatory infiltrate may be present, that is acute and chronic inflammatory cells may be present as well. Okay, so this is about your HP features of rhinosporidiosis. Now coming to the important viva question. So what is the causative agent for rhinosporidiosis? So it is Rhinosporidium seaberi, traditionally thought to be a fungus, but it is actually a aquatic protestant parasite. So what are the common sites of involvement? It is the nasal cavity, eyes, nasopharynx. Other sites include ear and skin. So what is the characteristic histopathological feature? We have already discussed. So what is the cause of granulomatous reaction in few cases? So basically, if there is rupture of the sporangia in the stroma, into the stroma, there is an intense granulomatous response. Okay. So the cause is the rupture of sporangia. Role of special stains, if any, yes. Past stain and and Gomori's methamine silver stain. Okay, so these are the two important stains which have a special role over here. So PAS stains the thick sporangial wall and the spores as magenta colored. So under the PAS stain, they are going to stain as magenta colored thick sporangial wall and spores, whereas under the methamine silver stain, okay, the sporangial wall and the spores are going to stain black in color. Okay, so they will stain magenta with PAS and black with methamine silver stain. What is the differential diagnosis of rhinosporidiosis? So two very important ones is, number one is coccidioidomycosis. So over here, remember, they are having smaller spherules and endospores, and mucil carmine stain does not stain coccidios immitis, but it does stain Rhinosporidium seabury. Okay, and another important differential diagnosis is mycospirulosis, which is composed of cyst-like spaces with clumped damaged RBC. So these are the two important differential diagnoses. So what are the risk factors? Okay, and which places are deemed endemic, not epidemic, which places are deemed endemic for rhinosporidiosis? Okay, so the risk factor is bathing or working in stagnant water, and it is endemic in southern India and Sri Lanka. Okay, so with this we have completed the discussion of one exam slide, that is rhinosporidiosis. Now coming to the next important exam slide, that is the case number 2. Now this case number 2, this is a 50-year female presenting with menorrhagia. So what we can see over here, we can see sheets of tumor cells, small round blue tumor cells can be seen, which is punctuated by spaces. Okay, which is punctuated by spaces, as we can appreciate over here. Let me take a lighter color so that it was easy for you to understand. So you can see sheet of tumor cells which is punctuated by spaces, empty spaces, and these empty spaces you can see over here, they are basically comprising of some cell debris, okay, which is surrounded by certain small round to oval cells with indistinct cell borders, pale cytoplasm, and the nucleus, if you see, they are basically round to oval, and there is a nuclear folding, as you can appreciate over here. Let me show you the nuclear folding. Okay, so you can see nuclear folding over here. Okay, very clearly you can see the nucleus is folded over here. Okay, not only that, there is also a single prominent nucleoli also over here, and there is nuclear folding also, as we can appreciate over here. Okay, very commonly nuclear folding is there. So what is the diagnosis? And remember, this particular space, this empty space surrounded by this tumor cell, okay, this is called as, yes, what is it called as? This is called as Karl-Exner bodies. Okay, because it resembles the Karl-Exner bodies of the developing follicle. So now you must have guessed the diagnosis. So this is the classical characteristic microfollicular pattern. This is the characteristic microfollicular pattern. Okay, and what is this? The diagnosis is adult granulosa cell tumor. Okay, adult granulosa cell tumor of the ovary. So if you look at the basic important HP features, so the microfollicular pattern is the most characteristic feature or characteristic HP pattern, consisting of nest and sheets of granulosa cells punctuated by small spaces, which is lined by granulosa cells that contain eosinophilic secretions and cellular debris, as you can see. So these are the empty spaces comprising eosinophilic secretions and cell debris. Okay, so these spaces resemble the Karl-Exner bodies of developing follicles, and therefore they are called as Karl-Exner bodies. So Karl-Exner body is nothing but this empty space containing eosinophilic secretion and cellular debris surrounded by the granulosa cells. Now the tumor cells resemble normal granulosa cells, so they are small and round, cuboidal or spindle shaped with pale cytoplasm and ill-defined cell borders. The nucleus is round or oval with fine chromatin and a single small nucleolus, as I have already shown you. And one important characteristic feature is the nuclear folding. Okay, this longitudinal fold or grooves, okay, which is present in many nucleus. They are characteristic feature of adult granulosa cell tumor, as I have already shown you over here. Okay, I have already shown you over here. Let me just zoom and show you. If you can see over here, okay, you can see the nuclear grooving. The groove is very, very important. You can see over here also one nuclear groove. You can see the nuclear groove over here also. See this? Okay, you can see the nuclear grooving over here, and you can see prominent nucleoli as well over here, as we have seen over here. Okay, okay. So mitotic figures and nuclear pleomorphism and ATP are unusual findings in these tumors but may be present. So now let us look at the important viva questions. Number 1, classify the sex cord stromal tumors of the ovary. I am not going to the details. There are broad headings include pure stromal, pure sex cord and mixed tumors. Classify the granulosa cell tumors. Okay, so the granulosa cell tumors are of two types. One is the adult granulosa cell tumor and another one is a juvenile variety. Absolutely, the adult variety is more common, comprising 95% of all cases of granulosa cell tumor. Describe the classical HPV features of AGCT, which we have already discussed. Okay, how is it different from juvenile, granulosa cell tumor? We are going to discuss. Okay, in the next slide. Just wait. And what are Karl-Exner bodies? Why is the cut surface yellow? The cut surface is yellow because the tumor is synthesizing a lot of hormones. This is the reason why the cut surface is yellow. Secondly, if you look at the histological patterns in granulosa cell tumor, there are many histological patterns which have been described, but they are often mixed with no prognostic significance. Most common pattern is the diffuse pattern, whereas the microfollicular pattern, okay, can be together with the diffuse pattern, okay, and the microfollicular pattern is the most characteristic one that I have already shown you. Other patterns include anastomosing bands, ribbons, cords in the trabecular pattern, okay. Macrofollicular pattern is least specific and least common, okay, for adult granulosa cell tumor. Okay, what is Karl-Exner bodies? We have already discussed. Okay, why is the cut surface is yellow? That also we have discussed. Now discuss the IHC of adult granulosa cell tumor and any new markers. Just remember, the most sensitive and specific markers include FOXL2 and SF1. So if you see, FOXL2 is 80% sensitive but 99% specific, whereas SF1 is most sensitive marker, and these are the newer IHC marker. Other markers include calretinine, inhibin. Now 50% cases will show positivity for S100, 70% will show positivity for CD99. This tumor is also positive for Vimentin. Reticulin shows a characteristic lack of pericellular staining, and the markers which are negative are the epithelial markers like EMA and cytokeratin. They are negative in this tumor. Discuss the molecular alteration seen in adult granulosa cell tumor. So the most common driver mutation which is seen in the FOXL2 gene, which is mutated in around 97% cases of adult granulosa cell tumor. Mutations in FOXL2 gene appears to be less common in juvenile granulosa cell tumor. So what is the prognosis of AGCT? It is a low-grade, potentially malignant tumor with a generally indolent course. This is the most correct form of prognostic, information in a single line. What are the differential diagnosis? Number 1 is juvenile granulosa cell tumor. Number 2 is cellular fibroma or thecoma. Remember this fibroma thecoma over here, the reticulin staining is showing a characteristic, pericellular staining, whereas in case of AGCT there is lack of this pericellular staining of reticulin. And last differential diagnosis is endometrioid carcinoma. So how do you differentiate AGCT from juvenile granulosa cell tumor? So very importantly, if you look at the juvenile granulosa cell tumor, so these are composed of cyst and solid lobular or nodular areas with predominantly macrofollicular, solid and cystic growth patterns. Okay, so macrofollicular pattern is more common in juvenile granulosa cell tumor. So how AGCT is different from juvenile granulosa cell tumor? So growth patterns which are common in AGCT, that is the microfollicular and the insular or the trabecular patterns, they are not seen in the juvenile granulosa cell tumor. Over here rather you will see macrofollicular, solid and cystic growth patterns. The granulosa cells in juvenile variety of granulosa cell tumor, that is juvenile granulosa cell tumor, if you see, they are often luteinized. They are large, polygonal to spindle shaped with ample amount of amphiphilic or pink cytoplasm, whereas in case of adult granulosa cell tumor, that the cells were smaller. Okay, they were smaller, round to oval in shape. The tumor cell nuclei over here is again large, round, and usually they are darkly stained, and bizarre forms may also be present. They lack the nuclear longitudinal grooves, and they may contain conspicuous nucleoli. Remember, they lack the grooves which was present in case of adult granulosa cell tumors. Some cells may have greatly enlarged pleomorphic nuclei and others are multinucleate. Mitotic fingers tend to be numerous and average around 6 per 10 high power field. So mitotic figures tend to be numerous and they average around 6 per 10 high power field. So this is again not seen in case of adult granulosa cell tumor. So with this, we have completed the discussion on adult granulosa cell tumor, okay, which is again a very commonly asked exam slide. Now we will go to case number 3. So what do you see over here? This is the case number 3. This is a 38-year male with a 6 centimeter shoulder mass. Now very important, what you see, you can see a lobulated tumor mass, okay, lobulated tumor mass, which is comprising of 2 types of cells. One type of cell is pale, eosinophilic granular cells, as we can see over here, with centrally located nucleus, okay, pale eosinophilic granular cells, okay, which is comprising central nucleus, and these are, forming the majority of the cells. Whereas other cells include your white fat cells, okay, or adipocytes, okay, the normal white fat cells. So you can see a mixture of these 2 cells. So if you look at the diagnosis, it is a classical case of a hibernoma. Look at the HP features. It is a neoplastic lesion with a lobular growth pattern comprised of a mixture of granular eosinophilic cells, which is exemplifying polygonal brown fat cells, and adipocytes. Classical hibernomas, they contain more than 70% brown fat. As we can see, the majority of these cells are eosinophilic, granular, polygonal in shape, and they are having a central nucleus, okay. Large number of pale and eosinophilic brown fat cells with multi-vacuolated eosinophilic granular cytoplasm. So in certain areas you can see multi-vacuolations can be appreciated, as you can appreciate over here. At certain areas, these cells shows multiple vacuolations, okay, and they show small central nucleus. They show small central nucleus, as we can already appreciate over here. So they show a small central nucleus, as we can appreciate over here, okay. So these features are very important because these features helps to differentiate the brown fat from the white fat, okay. This is mixed with variable amounts of univacuolated white cells. Along with that, you see the stromal cells in the background. Stromal myxoid change can be seen with increased number of stromal spindle cells resembling those of spindle cell lipoma. Nuclear ATP and mitotic activity is absent, and extramedullary hematopoiesis is an occasional finding, okay. So this is the classical histopathological feature of hibernoma. Again, a very important exam slide. So coming to the exam questions, so what are the sites of brown fat in the body? This will be the first question invariably. So it is the thighs, shoulders, interscapular region, and the back of the neck, or the nape of the neck that you say. Differentiate brown fat versus white fat. So as I already told you, one way of differentiating is by morphological evaluation. So morphologically, brown fat, if you see, they are polygonal, eosinophilic, granular, with centrally placed nucleus, and they are multi-vacuolated, okay, and the nucleus is present in the center. Whereas if you look at the white cells, so their nucleus is situated at the periphery because they are pushed by the fat to the periphery, okay. Along with that, there is another way that you can differentiate. Hibernoma fat cells, or the brown fat cells, they show UCP1 expression. So if you do the immunohistochemistry, if you do the IHC, the brown fat cells and hibernoma, they stain strongly with anti-UCP1 antibody. PAS-D will reveal PAS-positive diastase resistant cytoplasmic granules, and electron microscopically, hibernoma cells, they contain large number of mitochondria. Several large mitochondria is present, okay. So is hibernoma associated with any clinical syndrome? Yes, there is an association with multiple endocrine neoplasia type 1. Discuss the molecular alterations which are seen in hibernoma. So you will see translocations and deletions involving chromosome 11q13 to 21, most commonly at 11q13.1, that is the MEN1 or AIP gene locus. What are its differential diagnosis? Very simple: lipoma, xanthomas, granular cell tumor, lipoblastoma, adult rhabdomyoma, and atypical lipomatous tumor. Which is the most common soft tissue tumor in adults? It is lipoma. And what are its variants? So intramuscular lipoma, angiolipoma, chondroid lipoma, spindle cell lipoma, myolipoma, myelolipoma, dermal lipoma, pleomorphic lipoma, then extrarenal angiomyolipoma. Okay, so this is all about your hibernoma. Okay, so with this we have completed a discussion. Now we go to the next case, that is the case number 4. Now case number 4 is again very important case. It is a 56-year male smoker with a central lung mass. So what is the diagnosis? So what you can see over here, you can see sheets of small round blue cell with the nucleus being round to oval to spindle shaped at places. You can see diffuse sheets of cells. First thing. Second thing, you can see large areas of frequent necrosis. And if you go in the high power view, there are certain features which are very important. You can see several apoptotic cells. You can see a lot of mitotic figures over here. Yes, lots of mitotic figures can be seen. So there's a high mitotic rate is there. And very important, you can see certain nuclear molding over here. Okay, one nucleus which is taking the mold of another one. Okay, see over here another nuclear molding is there. So what is the diagnosis? Yes, a lung mass, central lung mass, a smoker, small round blue cell, diffuse sheet is there, and you are seeing frequent mitotic figures, extensive areas of necrosis, apoptotic bodies can be seen. So what is the diagnosis? Yes, you are right, it is small cell carcinoma of the lung. Very importantly, the tumor is composed of small round to oval cells with scant cytoplasm, finely granular nuclear chromatin, and absent or inconspicuous nucleoli with high mitotic count and frequent necrosis. Nuclear molding is seen as I have highlighted. The tumor cells are usually densely packed and commonly grow in a sheet-like pattern. Individual cell apoptosis is frequent as I have highlighted to you. Now remember, usually for the diagnosis of this small cell carcinoma of the lung, IHC is not required, but I am just discussing these markers because the examiner will ask you. So what are the neuroendocrine markers? And they are positive for this neuroendocrine markers. What are they? They are CD56, which is the most sensitive marker, chromogranin, synaptophysin, INS-M1. TTF1 positivity seen in 90 to 95% of the cases, but not specific. Napsin A, P63, P40, all these are negative. High molecular weight cytokeratin again is negative, and Ki7 index is very high. This is a highly proliferating, highly dividing tumor with a Ki7 rate of around 65 to 100%. Okay. So now let us jump into the important exam question. So enumerate the neuroendocrine tumors of the lungs. So there are broad headings. So there are precursors, there are neuroendocrine tumors, there are neuroendocrine carcinoma. So precursors including your diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. NET, that is the carcinoids, that is typical, atypical, and neuroendocrine carcinomas like small cell lung carcinoma and large cell neuroendocrine carcinoma of the lung. Okay. Now discuss the lung carcinoid. So there are two types, okay, of lung carcinoma. One is the typical, one is the atypical lung carcinoid. So what is the criteria? Let us see. So these are, so lung carcinoid, so these are neuroendocrine tumors with well differentiated organoid pattern. Now remember, the only neuroendocrine tumor of the lung which is not having an organoid pattern is the small cell carcinoma of the lung. Well, rest all of them, they have an organoid architecture. If you look at the division, so you have the typical carcinoid and then you have the atypical carcinoid. So how do you differentiate? If there is less than 2 mitosis per 2 mm square and they lack necrosis, so it's a typical carcinoid. Okay, and if the number of mitotic figures ranges between 2 to 10 mitosis per 2 millimeter square and with foci of punctate necrosis, then this is an atypical carcinoid. Okay, this is an atypical carcinoid. So this is your this thing. So remember the proliferation of index of typical carcinoid Ki67 is up to 5%, whereas that for atypical carcinoid the Ki67 is up to 30%. This is the cutoff. Discuss the classical histopathological features and IHC markers for small cell lung carcinoma, already discussed. How do you differentiate a large cell neuroendocrine carcinoma from small cell carcinoma? Remember, the differentiation is basically based on morphology, because IHC cannot help in differentiating large cell neuroendocrine carcinoma from small cell carcinoma. So let us see how it helps in differentiation. Large cell neuroendocrine carcinoma, remember, the diagnosis or the differentiation of small cell carcinoma from large cell NEC is based on morphology alone. As large cell neuroendocrine carcinoma, they have more abundant cytoplasm, distinct cell border, and vesicular nuclear chromatin with prominent nucleoli. IHC cannot help in differentiating between large cell neuroendocrine carcinoma and small cell neuroendocrine carcinoma. So based on morphology that I have already discussed right now. Discuss the prognosis of neuroendocrine tumors in lung, that I will discuss later on. I will show you the 5-year survival rate and I will show you that what is the prognosis based on the 5-year survival rate. I will discuss in the end. So what is Azopardi effect? Very commonly asked question. It is a crush artifact and it is characterized by encrustation of basophilic nuclear DNA. And from where this DNA comes? From the death of the tumor cells. From the death of the tumor cells, so whatever nuclear material is given out, that is basically depositing around the blood vessels as a basophilic nuclear DNA material. Okay, this is giving an effect called as an Azzopardi effect. So what are the characteristic molecular alterations which are seen in small cell lung carcinoma? TP53 and RB1 biallelic loss of function is compulsorily seen in small cell carcinoma of the lung. Enumerate the precursor lesions of the lung. So they are atypical adenomatous hyperplasia, adenocarcinoma in situ, squamous dysplasia, and carcinoma in situ, and DIPNIC, that is diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. Okay. Any paraneoplastic syndrome associated specifically with small cell carcinoma of the lung? Yes, Lambert-Eaton syndrome, encephalomyelitis, subacute sensory neuropathy. Remember, hypercalcemia is very rare, in small cell carcinoma of the lung. More commonly, this hypercalcemia is associated with squamous cell carcinoma of the lung and not with small cell carcinoma of the lung. Very commonly asked exam question. As I told you, this is a chart, very important chart, wherein you can differentiate between the different neuroendocrine tumors of the lung. So you start off with a typical carcinoid and atypical carcinoid. If you see, they are more common in females, more common in the 6th decade. Necrosis is not seen in typical carcinoid, but it can be focally present in atypical carcinoid. Mitosis per 2 mm is less than 2 and around 2 to 10 in case of atypical carcinoid, and Ki67 index is up to 5% in typical carcinoid and up to 30% in atypical carcinoid. Both of them, they have the typical neuroendocrine, the salt, pepper, chromatin and everything. You have organoid pattern. Okay, and very important, TTF1 is positive in the periphery in both and absent in the center. P40 again is absent in all, across all of them. I mean, if you look at the 5-year survival rate, it is the best for typical carcinoid. It is between 80 to 100%. For atypical carcinoid, it is 50 to 70%. Okay, now coming to the carcinomas, that is small cell lung carcinoma and large cell neuroendocrine carcinoma, both of them are common in males and in 7 decades, and necrosis is present in both of them, and both of them, they contain more than 10 mitosis per 2 mm square, and even the Ki67 index is between 30 to 100%. But remember, typical neuroendocrine organoid pattern is absent over here in small cell carcinoma of the lung, whereas it is present over here. Again, TTF1 positivity is seen in both the cases. Again, it is a non-specific marker. And again, the 5-year survival rate for both of them, they are less. For small cell carcinoma, it is 31 to 34%. And this is also similar. Both of them, they are highly aggressive neoplasms. Okay. So with this, we have completed the case number 4. Now we are coming to case number 5 discussion. So this is basically a routine PAP. Okay. An LBC. This is a liquid based cytology slide. So how will you know which slide is conventional? Conventional slides are dirty. LBC slide, you will see that, they are confined to a particular space. It's a 32-year female. So what you can see abundant superficial and intermediate squamous cells over here. And what you can appreciate over here, there are certain cells. So this is the normal squamous cell. This is the normal intermediate cells, as I can appreciate. Okay. But over here, there are certain cells, as you can see, where the nucleus is much larger, more than 3 times the size of intermediate cell. And what you can appreciate also is a perinuclear clearing. What is this change known as? This is called as coelocytosis. Okay, this is called as coelocytosis. So basically, certain, and the nucleus, at certain areas you can see it is bit hyperchromatic. Okay, bit hyperchromatic, as well as nuclear membrane at places they are showing notches. Okay, they are showing bit of notch at certain areas. So what is the diagnosis? Yes, it is a diagnosis of L-cell, that is low grade squamous intraepithelial lesion. So what are the important features? Let us try to understand. The cells occur discretely or in clusters or sheets. Cytological changes are only seen in those squamous cells, okay, with mature, intermediate or superficial squamous cell type cytoplasm. So cytological changes are confined to only those squamous cells whose cytoplasm is mature, intermediate or superficial squamous cell like. Okay, such cells are abundant and mature. Okay, abundant such cells are there, and only such cells are showing the cytological changes of your L cell. The cells are larger in size. The nuclear changes, if you see, they are the most important changes for the diagnosis of L cell, as I have already shown you over here. So the size of the nucleus is more than 3 times the size of the nucleus of the intermediate cell. So the average size of nucleus of the intermediate cell is 35 micrometer. For ascus, the average size is 100, and for L cell it is anywhere between 150 to 175 micrometer. Okay, nucleus NC ratio, it varies from normal to slightly increased. Why? Because the cytoplasm is yet abundant. That is why the NC ratio doesn't vary that much. Normo to hyperchromatic nucleus with anisonucleosis can be there. Chromatin ranges from coarsely granular to smudgy to densely opaque. Nuclear membrane, for most cases they are smooth, but at certain areas you can have certain notches like this, as I had shown you. Nucleoli is absent or inconspicuous, and bi-multinucleation is common. If you look at the changes which are present in the cytoplasm, try to understand. Okay, the cytoplasm, if you see, is abundant and mature. So the nature of the cytoplasm is abundant and mature, and the cytoplasm is well defined. They may show keratinization with dense orangophilic cytoplasm, and they may show coilocytosis, which is a HPV associated viral cytopathic effect. What is this coilocytosis? As I showed you, there is a perinuclear clear zone sharply demarcated from the peripheral rim of dense cytoplasm. Okay, so remember one thing, just presence of coilocytosis is not enough for diagnosis of LCIL. Rather, the nuclear features are more important for the diagnosis of LCIL. Remember this point. Although they may help reach the diagnosis, they are not an absolute prerequisite. Remember, coilocytosis and keratinization, they are not an absolute prerequisite for the diagnosis of LCIL. Nuclear features are far more important in the diagnosis of LCIL. Remember this point, okay? Many points I have discussed in this description only. So what are the cytological features of LCIL, which we have already discussed? So most important question will be highlight the main points of the Bethesda reporting of cervical cytology smear. Okay, so first is the specimen type, then you write down the adequacy, general categorization, interpretation, any adjunctive testing was done, and advice. What is the role of E6, E7 oncoprotein? E6 and E7 oncoprotein, they act by inactivation of P53 and RB tumor suppressor genes respectively. Discuss the basic nomenclature of squamous cervical precursor lesion, that is the LCIL and HCIL. Now remember, let me just make you understand the basic nomenclature. So initially we had cervical intraepithelial neoplasia, we had SIN1, SIN2, SIN3, SIN4 and carcinoma. WHO, according to WHO classification, you know, SIN1 corresponds to mild dysplasia, SIN2 moderate, SIN3 refers to both severe dysplasia as well as carcinoma in situ, and carcinoma is carcinoma. Whereas according to Bethesda, there is only two precursor lesions. One is LCIL corresponding to mild dysplasia and SIN1, and HCIL corresponding to moderate dysplasia, severe dysplasia, carcinoma in situ corresponding to SIN2 and SIN3, and carcinoma as it is. Now if you look at the basic natural history, okay, of these precursor lesions, around 10% of LCIL is going to progress to HCIL. Around 30% will persist and 60% will regress. Whereas if you look at HCIL, 10% will progress to carcinoma, 60% will persist and 30% is going to regress. Okay. So this is the basic nomenclature of cervical precursor lesions and carcinoma. So how do you appreciate coilocytosis microscopically? I have already discussed that point, so I'm not repeating again. Perinuclear clear zone sharply demarcated from the peripheral, dense cytoplasm. So this part, this is the coilocytic area. This is the dense cytoplasm. Perinuclear clearing is there. Now you will not find this answer very clearly anywhere. The next question that is there, how do you appreciate coilocytosis microscopically? Already answered. And what is the pathogenesis behind it? Why does it occur? So it occurs due to the E4 oncoprotein, okay, which is disrupting the cytoskeleton because of the E5 and E6 oncoproteins, which acts together to promote formation and fusion of perinuclear cavitations. So if you have to choose one answer, it will be E5 as given in Robbins, okay. But if you can answer, if the examiner is if asking for more, or if he is asking for a single answer, then go for E5 and you can quote Robbins. Else all E4 and E5, E6 together, they are helping in coilocytosis. Is coilocytosis necessary for diagnosis of LCIL? No, it is not necessary. Nuclear features are far more important for diagnosis of LCIL. Now coming to more important questions over here, because the the Viva will basically go now towards the HPV screening or the molecular screening of HPV, okay, and it will also go towards cervical carcinoma as well as the various screening tests and the vaccines which are available. So what is the role of molecular testing? Okay, role of molecular testing of HPV in screening cervical carcinoma. So it is used for triaging, it is used as a test of cure, it is also used as a primary screening tool with increased sensitivity but decreased specificity. Okay, screening using HPV testing is done between 30 to 65 years every 5 yearly. Okay, so screening using HPV is done between 30 to 65 years every 5 yearly. So name some HPV based tests. So there is hybrid capture, which is hybrid capture 2 assay, which is RNA DNA hybrid based model. Then we have Abbott real time and Roche Cobas, which is DNA PCR based model. Gene probe Aptima, which is mRNA based PCR model. Hologic Cervista, which is a DNA PCR based model, and we have On Clarity, which is a DNA PCR based model. Now classify the carcinomas of the cervix in accordance with the current WHO 5th edition, and also state the recent updates with regards to classification and the rationale behind it. Now classification you can read, it is already discussed in detail, so you can read. So what is the changes, current change? So remember, carcinomas in both the squamous and glandular categories, they are now classified as either HPV associated or HPV independent. This is the biggest change. And why this change is there? Because though almost all the cervical squamous cell carcinomas were HPV associated, majority were HPV associated. However, certain HPV independent squamous cell carcinomas, although very rare, was described. So that was the rationale that we had to divide. Although the HPV independent varieties of carcinomas are less, yet for example they are there. Okay, so this is the rationale behind division. Okay, now what is VIA? It stands for visual inspection with acetic acid. It is done after an abnormal pap, when you know that okay, the pap is abnormal and I have to take a particular sample from there. Okay, so abnormal areas are highlighted using this method, and with this method, with this testing, abnormal areas appear as opaque white areas called as aceto-white area. What are the high and low risk HPVs? Low risk HPVs are HPV 6 and 11, and high risk HPVs include 16 and 18. If they ask you to answer more, you can add 31, 33, 35 as well. Now what is LBC? LBC is liquid based cytology, and name commercially available LBC, they are ThinPrep and SurePath. How do you differentiate between the two? I have discussed in details. Okay, so I'm not repeating over here again. And name some automated cervical carcinoma screening methods. So they are BD focal point GS imaging system and hologic ThinPrep imaging system. Now one very important thing is the screening, cervical carcinoma screening. So how does it start, when does it start, and how it is carried? So less than 21 years, no testing is required. The between 21 to 30 years, PAP testing has to be done every 3 years. Between 30 to 65 years, PAP test done every 3 years. Okay, if you are combining HPV along with the PAP, then you can do every 5 years. So HPV testing starts after 30 years, not before 30 years. Okay, 65 years and older, no testing is needed. And regarding the various vaccines, this is very, very important. Favorite question of examiner, they will ask you. So there are 3 important vaccines which are currently available. One is the Cerevarix, which is the bivalent vaccine, which is covering HPV 16-18, and they are applicable for females between 9 to 26 years of age. Then you have a Gardasil, which is a quadrivalent HPV vaccine covering HPV 6-11, that is the genital warts, as well as HPV 16-18, and both males and females can take this vaccine between age 9 to 26 years of age. Then we are having Gardasil 9, which is a nonavalent HPV vaccine covering HPV 6, 11, 16, 18, along with that 31, 33, 45, 52 and 58. Both males and females can take between 9 to 45 years of age. So with this, we have completed the discussion on this particular slide, that is of LSIL. Okay. Now we are going to our next case, that is the case number 6. So what is this case? This is a 42-year male.